So we've talked a lot about how foods can interact with drugs, but drugs can also create marginal nutrition deficiencies. So certain antibiotics and diuretics can reduce blood levels of potassium and other electrolytes. Cephalosporin is associated with decreased vitamin K levels, and rifampin is associated with decreased vitamin B, niacin, and vitamin D levels. Tetracyclines are associated with reduced absorption of calcium, riboflavin, and vitamin C. Aspirin, diuretics, and acids, and certain oral contraceptives can reduce the absorption or activity of many vitamins and minerals. So phentoin is associated with decreased calcium absorption and decreased vitamins D and K and folate. Cholestyramine, remember this from earlier, may interfere with absorption of fat-soluble vitamins. So think about what cholestyramine was doing, was sequestering those bile salts. Methyl dopa is associated with decreased vitamin B12, folate, and iron. And levodopa can cause decreased vitamin B6 levels. So an important aspect of the RDN's job in the ICU or hospital setting is monitoring for the influence of medication administration and enteral feeding. So pharmacists are often unaware when a patients are placed on EN. Common concerns are inadequate intestinal absorption of the drug, toxicity, potentially by the lack of degradation by stomach acid, or toxicity resulting from decreased first-pass metabolism. So it really matters where the tube is placed and where it ends. For example, antacids, bismuth, and saccharofurrate need to be delivered into the stomach. They cannot be administered in tubes that end in the intestine. Clearly, we want to make sure antacids go to the stomach because that is where acid is. Medications with high first-pass metabolism need to be delivered to the jejunum, that are delivered to the jejunum, the bioavailability can be increased. This includes beta blockers, nitrates, opioids, and tricyclics. And cholestyramine, enteric-coated tablets, and bulk-forming laxatives have higher likelihoods of clogging tubes. Similarly, Savelmer turns into a gel, and antacids bind to proteins, which can additionally block enteral tubes. It's also important that we consider the pharmacokinetics of protein energy malnutrition on medications, and keep in mind that reductions in both adipose tissue and lean tissue can change pharmacokinetics. In protein energy malnutrition, extracellular fluid volume may expand, so you'll have too much extracellular fluid. You may see reductions in cardiac output with reduced hepatic blood flow and glomerular filtration rate, which means decreased excretion. And hepatic protein synthesis rates are also reduced during protein energy malnutrition. Sorry, that should be an E. We also see reduced transport proteins and regulatory hormones that can influence drug distribution. So think about in protein energy malnutrition, what acute phase proteins decrease? Albumin. Albumin transports almost everything, it seems like, but also medications. So, like I mentioned, this reduced cardiac output, filtration rate, all of these can influence drug elimination. And we know that CYP functioning can be reduced in protein energy malnutrition. And we saw that in the kwashiorkor. So there is considerations that need to be taken for individuals with obesity. Increases in adipose tissue will increase both lean tissue and body water. So then it is up to the pharmacist to decide what weight to use when prescribing different medications. Individuals with obesity often have a larger cardiac output with tissue, blood flow, and the glomerular rate, but a low proportion of blood flow to adipose tissue. So screening for drug-nutrient interactions obviously is important. And screening may be indicated when the efficacy of a prescribed drug is suboptimal, when a nutritional status unexpectedly changes, or when blood testing indicates a toxic drug level. How we do this is first looking at the patient's diet, screening for components that are known to interact with the medication. So, how would you do this? There's a couple of different ways, but I want you to think about that. If any interactions are found, either a change is made in the patient's diet or an alternative medication is selected to avoid the interaction. The risk for drug-nutrient interactions can be reduced by limiting the number of medications the patient is taking to only those that are absolutely necessary, and by using medications for as short a period as possible. So the registered dietitian, nursing personnel, or pharmacy personnel may take part in the screening process. Patient education is important because the patient has to be actively participating in the detection of possible drug-nutrient interactions. And it is appropriate for family members to be present to look for possible drug-nutrient interactions, especially because the patient themselves may feel overwhelmed, they may not feel well at all, and they may be frightened. So we can prevent interactions, changes in the pharmacokinetics or pharmacodynamics of a medication by nutrients can happen, but basically we just have to look for a change of effectiveness in the medication and see if any foodstuffs may be responsible. And this is important because it can prevent serious medical problems and nutritional deficiencies. Failure to manage and identify nutrient interactions can result in serious medical problems. And undetected interactions can lead to treatment failure that may worsen the patient's condition or even lead to death. And unfortunately, these serious consequences may be mistaken by clinicians as a reflection of disease progression. So they may not realize that the disease isn't progressing, but that a food or nutrient is interfering with the drug. So preliminary steps before screening. Review the facility or unit's protocol. Review the treating clinician's order. Review the patient's medical history. Note any allergies, history of drug-nutrient interactions, current medications, and typical diet. And then this is a protocol on how to provide screening for drug-nutrient interactions. I won't read through all of this, but of course, please make sure you wash your hands. Explain the process and advise the patient of what to expect and the typical duration. Ask the patient to list all medications and supplements being used and about the perceived efficacy of medications and supplements. Ask whether the patient regularly consumes foods and nutritional supplements known to interact with medication, so grapefruit juice, St. John's wort. If a drug-nutrient interaction is suspected, Reinforce the clinician's explanation of the importance of avoiding or limiting a certain dietary component. If the patient cannot or will not, collaborate with the treating clinician to offer a potential alternative medication. Um, and medication should be reevaluated regularly to screen for possible drug-nutrient interactions. And again, this does become more complicated as the patient or participant is using more medications. So update the patient's plan of care if appropriate, document the screening process, and include the following information. Laboratory tests may be performed, especially if a drug is acting particularly odd. And never suggest that a drug is crushed or diluted for administration into feeding tubes. This is a huge no-no. And this is because some drugs may have their properties altered when they're crushed or diluted. So this is just what to expect after a screening. Um, this is kind of the ideal, that they will not be experiencing the drug nutrient interaction. Foods will be omitted or replaced, and that the medications that interact with commonly ingested foods may need to be replaced. So it can be important to include the patient's family. This can encourage compliance, provide written information about the drug nutrient interaction risk, and reinforce the importance of carefully reading all medication labels. And these are some good links to help you, because there's a lot of drugs out there. It's not your job to know all of them, but it is your job to help prevent drug nutrient interaction.